Welcome to the Red River Medic Podcast, breaking rules, challenging norms, and changing EMS for the better. On this episode, we go to the unlikeliest of places to hear about innovations on pain management. In Cheyenne, Wyoming, they have created a pain protocol that focuses on alternates to opiates prior to reaching for the morphine and fentanyl. So turn up the volume and let's get into what is going on around the world of EMS and see if we can actually make EMS better, one real conversation at a time. On this, the Red River Medic Podcast.
This show is for medics who aren't afraid to stir the pot, ask the hard questions, and challenge that we've always done it that way crowd. So like I said, let's top off that cup of whatever it is that you're drinking, buckle up, and get into it. Now, like many of us, we are very comfortable, and it is commonplace for us to give pain management medications. But most of us in our repertoire, in our protocols, have narcotics as our only choice. But at Cheyenne Fire, they're doing something a little bit different. So let's get into it and let's talk about it today. So thank you, Brice, for coming on today, and let's dive into this important and monumental topic. Brice, why don't you start off with a little introduction about yourself and why you are so passionate about this topic?
Hey, and thank you for the invite, Dave. My name is Brice Jacobson. I am the EMS coordinator for Cheyenne Fire and Rescue. I've been in EMS for 27 years, 22 of those as a paramedic, 21 of those as a firefighter paramedic here in Cheyenne, Wyoming. I also am involved with the actual chair of our protocol committee. So in our system here in Laramie County, my little corner of Wyoming, we actually work as a whole system. So we have one single medical director and all the different services work under that. We have one set of protocols. So one hospital, everything kind of is a cohesive unit as far as we look at everything. Part of the reason why I am actually very passionate about non-opiate medications is, being in the medical industry. One of the things that I always hated was we had those patients that weren't really in enough pain that you felt like opiates were appropriate, or you just had those patients that you were just like, yeah, this is drug-seeking behavior, and there's nothing I'm going to do for you. Problem is where's the ethical line in all of that? So what we did a few years ago is we sat down and went, okay, what can we do better? Well, it happened to be that Colorado came out with an ALTO initiative, and that's an alternative to opiates. So what they did is they started looking at how can we make this all better without the use of opiates and still treat our patients better, and what can we do to make them feel better throughout the whole process of their care, just to kind of see if we can make things better for them as far as the outcomes go. And so what that did is it influenced our hospital here, and our hospital started their alternative opiates program. But what happened was they were being brought in by EMS prior to that. So they were finding that we were actually messing up their study, messing up what they were wanting to do, and really kind of throwing that for a loop. So they came to us and said, well, what can we do in the EMS world? And so we sat down with them and developed our protocols and put those out, trained on them, and put them out the streets, and actually got a lot of positive feedback from our providers out on the street. So
now, Brice, many moons ago, you and I got the opportunity to work together, both on the ambulance and as a ambulance paramedic and a fire department paramedic. And I remember back in the day, pain control was fentanyl, maybe ice, maybe a little bit of Tylenol. What's different about your pain control protocol, and what makes it innovative and different from what we're all accustomed to?
So one of the things is that our approach wasn't a get rid of opiates altogether. That's where a lot of people, when we started this process, that's where we thought we were going to go. The point of it wasn't to get rid of those, it's to use those as an adjunct or use less of those. So what I found was we didn't use Tylenol in our system here. So that's one of the things we did add in our protocols. But what we also did is we took things that we already had and we used them differently. And what I mean by that, if you've ever taken care of a patient that has a history of abdominal pain, especially GI issues, and you have them and you look, we thought TCAs were they're old school, we don't use them. And if you've seen that influx, that's why they're probably on that, because those are some of the things they're using the different chemistry of a tricyclic antidepressant or general antidepressant for something that's not antidepressant related. So those are the kind of things that we were, these are some great data, some great science behind it. Toradol is a prime example of that. If you think about how many times a provider would give Toradol, like, well, it's just for kidney stones, right? And most of the time, the provider's like, oh, well, I just gave him some fentanyl, not a big deal. Like, Toradol was the last of their thought. And one of the things we did is we went, well, we can lower the dose so it's less harsh on the kidneys, but we can get a better result. And those are the kind of things that we started doing. And once we started introducing this and we started looking at the data and science, we went, these are things that are already in medicine, if you really think about it. When you think about diabetic neuropathy, they're not using opiates, they're using something else. When you're talking about the GI symptoms I was telling before, they're using antidepressants. So we're using these medications in a different way than they were originally intended to get the results that they want. And so when we started looking at that, we were like, why can't we do the same thing in EMS? EMS itself does not typically think that way. We have such a short window of having that individual and taking care of that patient that there's not much wiggle room in a lot of the things that we do. So what we had to do is we had to think, okay, what can we do with the tools that we already have in our toolbox, using them differently. And then when we use them differently, how is that going to affect our patient's outcome? And what we found was we actually had some really positive outcomes. We use Zyprexa as an antipsychotic in the system example. One of our first successes was our paramedics went, we don't think this is going to work, we're going to give it. Before they gave any opiates. They gave the Zyprexa, so they gave this antipsychotic. Patient has a history of diverticulitis. So this is the best she's felt in a long time as far as pain management goes, because she didn't feel groggy, she didn't feel overwhelmed, she just didn't feel that feeling that you get with opiates and having to have a ton of opiates to get on top of her pain. She was still in pain, but it became more tolerable. So those kind of things started showing some early successes. Another incident was we had a patient that had fallen, broken her hip. Normally that would be fentanyl and Valium or morphine to follow it up with, so giving a ton of opiates. They gave Tylenol and they gave Valium. That was it. And this patient didn't receive anything until she got discharged, any opiates. She was able to maintain her pain on what we gave her, and when she went to surgery to have her hip replaced, they did a nerve block, so she didn't need any pain medication when she got out. So it wasn't until she actually went home that they gave her the pain medication and she was on opiates then. So we're finding some good successes. It's not a one-size-fits-all, but some good successes in a lot of our cases. And then when we look at how much usage, we've actually had a 35% reduction in our opiate use by going with this. So, we've seen some good cases with what we've done.
35%, I would say, is very successful if you're able to reduce the amount of opiates you're having to give in your system. Now, that gets me wondering, when you started to think about this idea of Zyprexa in your system, what did your employees, what did the paramedics think? Because Zyprexa, that's not a medication that they're taught in paramedic school. And I don't know about you, but a lot of the paramedics that I meet are not really into brand new ideas or kind of that far outside the box concept. How did they embrace the idea of some of these new protocols?
It took some work. No, not everyone embraces it. That's the hard part. But a lot of what it was a lot of front loading and a lot of education. So how we knew this was going to happen, we knew we were going to read the resistance, we knew there was going to be those questions. We kind of had an idea. Being in EMS as long as I have, you start to get to know change. We don't like the way things are now, but we also don't like change. So there's kind of that mix of back and forth. So that's where we had to front load all that stuff. So what we did was we contracted with the doctor and his group down in Colorado, and they did a lot of podcasts and videos and stuff. And what he did is he created a bunch of educational videos. So if we had 4 hours of educational videos that talked about what pain was, really kind of going back to what we learned in paramedic school, really what pains are, what the different types of pains, opiates, the history of opiates, like kind of trying to give as much knowledge to our providers as we could. And then we had a sit-down session with all of our paramedic providers in the county. And he actually was in the middle, and it wasn't just a PowerPoint. He literally sat down and said, let's have a discussion. Let's talk about this. So it was, here's a case scenario. What do you think? And that really was the big help with a lot of that. Our medical directors were on board. We had one medical director that her only worry was like with Toradol, was we learned in paramedic school, is, oh, there's the bleeding risk. Well, the data and science we started looking really isn't there. So they just had to show the science. We had to ever sit down with our surgeons and stuff like that. They're already managing bleeding disorders right now with all the regular medical patients, and Toradol is the least of their risk. So it was kind of getting rid of some of that stigma and stuff we've already had in our head for years. Well, if I give them this medication, this is what's going to go, here. And that kind of did help, but it's really having those discussions and really sitting down and teaching them the why that a lot of them bit off on it. Now, like I said, there was some resistance. Those first couple of cases, those were some of my anti-change. This isn't going to work. I'm going to prove you wrong. That was actually end up being my biggest champions, because what they did is they went, I'm going to prove you wrong and I'll show you. And then they went out and did it one time. And they went, crap, this was luck. Then they went out and did it again. And they went, twice, this can't be luck. But I still don't believe it. And then they did it a third time and they're like, I had 3 success stories by using non-opiates, by using what you told us to use. I can't believe it. And so then they ended up being a huge advocate, and they were the ones that were on the background going, hey, this does really work. Like, they were standing up in our case reviews and they were going, hey guys, I'm telling you, this works. Here's my experience with it. And then this even helped even more because where we work with GMR in our area, they had their medics that use a lot more than my fire medics do. And so they were standing up and saying, here's my success stories. Here's what I'm doing that's been successful. Here's what I'm telling me better care for my patients. And so what that's done is then we now have testimonials in a lot of ways that say, hey, this has been successful for me. Some people just like, I'm still not going to use it. That's fine. Like, that's the tool in the toolbox. But there's been a lot that have been like, absolutely love it. I'm glad I went to this. This actually, I noticed my patient actually had a better outcome, a better experience. So, I mean, those are some of the things, yeah.
And those are 2 huge points that I think get missed. Number one, turn your negative Nellies into your champions, because they carry so much power when they change their tune. And we all know in EMS we have a tendency to be a little on the negative side. And so when we change our tune, and man, the other side of that is, boy, in EMS we don't like change, and the only thing we hate more than change is not change. So the downstream effect now, so you got your teams that were starting to jump on board and becoming advocates. What about on the hospital side? You kind of hinted about the hip and the orthopods, but what about the surgeons? When they see that this patient had gotten Zyprexa and doesn't have a psychotic disorder of some kind, that you were given this medication for pain control, how are the surgeons taking it? Because, that's another group that has a tendency to be opinionated and kind of dug in their opinions about things.
So they didn't give as much resistance as I thought. Part of this is they were already doing some of what we're doing in the hospital before we started. So it started its roots in Laramie County in the emergency room. So they were already dealing with it in that juncture. So what they had done beforehand when they were training their ER physicians is they had their surgeons talk to the physician that actually trained us and trained the ER. And him and his staff had those peer-to-peer, and that opened up a lot of those bridges and broke down a lot of those barriers. So once they started like, oh, hey, this is some good things. Because as an example, we've been using ketamine in the system for pain management for a while. They just only started going to it once the pandemic started. So we were already kind of ahead of the curve on a lot of that stuff. So they were already kind of like, ketamine? Oh, you guys are giving them ketamine now? Okay, we can continue that. And then when they get to the ER, they're like, oh, you gave them Tylenol? Okay, great, because they're already used to them being in Tylenol when they get to the ER. So some of this was an easy transition for us, and some of it was already kind of front-loaded before we came into the picture, because they already been doing the Alto stuff about 6 months prior to EMS even starting the process. So they'd been into about a year and a half by the time EMS actually started doing it in the field. So it wasn't that much of a resistance. Like I said, it was more on the EMS providers than anything else. But if I looked at their protocols and our protocols, I mean, there's some nuances, but they were actually very, very similar in how we went about it. Using an antipsychotic for abdominal pain, using ketamine the way we did, using acetaminophen, using Toradol in the way we were using it. So it was kind of gratifying for us to say, hey, we have this protocol here and our protocol, and it almost mirrors each other. And we didn't even know what each of us were doing. So it was kind of very, very exciting for me to be like, hey, they're on the cutting edge, we're on the cutting edge. We didn't even talk to each other, and we ended up with the same conclusion as I thought was a positive result.
That is very awesome. And when independently you kind of come to the same conclusions, you probably are doing something right. So that's super cool. I imagine I probably know which system it is down in Houston that's doing that. They've got a lot of outside the box thinking down in that area. So the literature, where do we sit on the literature? Is there a lot of studies out there? I'm sure some of our viewers are going to say, well, or their medical directors are going to say, show me the literature, show me where it actually has been published, where there's been studies. Do those exist? Are they out there?
There are some studies, and they're kind of almost siloed or individual based on the medication. An example is Toradol. Well, we had seen the preliminary results on the Toradol, but they didn't have their final results published. And some of that was they're seeing the same results in pain management with 7.5 instead of 10 or 15 or 30 that some individuals are giving. So those have been individual studies that we kind of use together as far as that goes. As far as resources, Colorado, before we started our program, they started piloting this at several hospitals across the state. And what they found is when they went to their ERs, train their individuals on this. And again, they're using a more expanded scope than we are. And the ER, they're training their physicians to do more locals and nerve blocks, those kind of things to help with their pain management instead of just medications. And what they found within a year of them starting their study and checking these pilot hospitals, that they were having such great success and still doing a good enough job with their pain management, that the hospital system across the state went, this is the new latest and greatest thing. Everyone needs to be doing this. And so they started training their providers on all of this. If you're talking any particular studies, there's a lot of little individual studies. If you talk to any physician, nurse practitioner, a lot of the education in the last decade have been, how do you manage your patients without opiates? And again, that's where you come in with those individual treatments. Like I was saying with neuropathy, or diabetic neuropathy or any kind of nerve pain, they use anti-epileptics. And so that's where kind of some of the stuff is, hey, how can we do these better? Part of it comes from physician education. Part of it comes from just individual studies like that of how to manage it. Part of it is just the general education that physicians and nurse practitioners and PAs and all those get now of how to manage these patients a little bit better.
So if I wanted to get a copy of that protocol, is that something that's available? Can they reach out to you to get a copy if somebody wanted to see what it is that Laramie County, what Cheyenne Fire is doing? Is that available?
Yep, that is available. Right now we're working on getting it actually published onto our website, so that way anyone that wanted a copy of it can have a copy of it. I'm always willing to share our ideas. I also understand that, every state works a little bit differently and you have to work within the confines of their state. But I'm always willing to share that because our protocol was also designed not just for what paramedics can do. The state of Wyoming is going through a scope of practice change currently. So one of the things that they've added is over-the-counter medications. So some of what we've built into our protocol is actually going to be a benefit for our EMT basics in the system, because we are a very rural county in various parts. So if an EMT basic is waiting 45 minutes to an hour for an ambulance to get there, they can give them some Tylenol, some Motrin. They can give, if they're advanced, they can give nitrous oxide, which is kind of part of our protocol as well. They can give oral medications to kind of help with some of that pain management before the paramedic even gets there. And that actually puts things kind of even farther ahead, because if we get there and you're not managing it with Motrin and Tylenol and nitrox or anything else like that, then that gives them a direction more with the opiates than they would without. So it's just kind of opens up a box of possibilities for all scopes of practice to be able to do more with pain management.
So what about those conditions, trigeminal nerve injury, where it's not uncommon to see them getting 20 and 30 or more milligrams of morphine to control their pain. Your femur fractures, where the pain is just tremendous, and 100 and 200 micrograms of fentanyl just isn't going to cut it. And a lot of our systems, our protocols say, give that fentanyl. If that fentanyl doesn't work, then switch over to ketamine. Are you finding out that some of these other medications are as effective, or in combination allow you to give less opiate and maybe more of these others?
Absolutely, it does. One of the things that and it's a common thing that you're starting to see more and more pop up now. It's called multimodal. So what you're doing is you're attacking that pain from multiple different angles. So instead of just blocking the nerve, blocking the pain of the central nervous system, now let's block it a different way. So when I do have to block it with opiates, I'm actually using less opiates. So I'm using about half to three quarters. And if they're really in a lot of pain, as much as I would normally. So I'm able to control that pain just a little bit differently. But what we've also done is more than just the medications. We've actually tried to look at it from a change of the pain psychology itself, which is some of the stuff we learn. Because if you think about it, how you were trained, if you have pain, you have a pain. What's your pain scale? 1 to 10. What's your pain scale? And our goal was always to get it as less as possible. Let's get it down to as close to 1 as we can. Well, one of the things we have to stop doing is saying, okay, well, that's always our target, because we have to ask that patient, what can you tolerate? That was the other part of what we changed is that question, because we know a rancher that can walk around with their leg almost lopped off, and we know they're in pain, but they're like, just sew it back together. I got cattle to go. Let's go. And then you have the person that's got a paper cut, and that's the worst pain of their life. So how do you manage those patients differently? We know the rancher and farmer doesn't want any pain medication because he can tolerate it. So why am I giving him stuff that he maybe doesn't want? But maybe the person with the paper cut, well, what would be tolerable? Well, 1 or 2 or 3 or 4, right? So a lot of that is, what can you as an individual tolerate, or what are you willing to be able to tolerate? Because we can't get rid of their pain, but if we can help maintain that, or take enough of an edge off, that's what most people want, is just make it comfortable enough to where I'm not rivaling in pain. I don't want to be pain-free, but enough to where I can tolerate it is more where the target is. And so when we give them that option, one, they feel more like they're in control, and two, they feel like that you're actually involving them in that decision. So we're actually seeing a lot better patient satisfaction scores because of that.
Now, onto your algorithm, and we'll make sure that we post up that algorithm. But in that algorithm, you have different pathways for different complaints of pain. It's not that if you have a headache, or if your leg is completely broken with a bone sticking out, that everybody's getting the same things. So what are the different pathways in that protocol, and then what medication goes with what route?
So a lot of it was just specifically say, because every pain, to understand that the pain psychology, every pain is different. A musculoskeletal pain is not the same as GI pain, which is just not the same as neuropathic pain. So each pathway was designed specifically for that. An example of that would be our headaches. So if you've ever been to the ER for migraine headaches in the last 20 years, they just don't automatically load you up with opiates. What's one of the first things they give you? Benadryl. Well, that's not very well known or very well pushed in the EMS world. That's like, okay, yep, you have an allergic reaction, that's what Benadryl's for. Okay, maybe some from abdominal pain or some nausea, okay. But now you have a migraine. Here you go. Here's some oxygen, and here's some Benadryl. And those are things you're like, hey, we're seeing better results from that than we would with opiates. Because again, you're opiate over opiate until almost they stop breathing, where now they're actually getting some more pain relief by the histamine release of that Benadryl. And the same thing if you go down that pathway, the cannabis-induced hyperemesis is another thing. We can give Pepsid, we can give that, but like Benadryl is another example of that. Like we're attacking it from multiple different angles from that. And then you get into the musculoskeletal. Again, we're using ketamine, still using Tylenol and Motrin, but maybe more in the ketamine than you would with some other stuff. So a lot of those is just pathways that we're trying to design specifically for that. Abdominal pain, you maybe have an option for ketamine, but again, that you're not going to give that Zyprexa for musculoskeletal pain. It's not going to work that way. So it's only in our abdominal pain pathway. So, just trying to be a little bit more specific to what the actual issue is and where that pain is actually originating from.
Now, you talked about working on an article to publish in the near future, and I will most certainly be one of the first people to definitely be reading that when it does get out. But from internally, what have the patients been saying about how this manages their pain at the hospital and through their course of treatment? Are you seeing significant improvements in their pain management? We talked about you're using less opiates, but is their pain going down from a 10 to a 2, and is it staying at that 2 through the entire course of transport?
They are seeing a really good pain reduction throughout transport. The greatest part is once we get to the emergency room, because again, we're not focusing on making it pain-free. It's reducing their pain what they're tolerable, or what makes it tolerable for them. And then the great thing is most pain that they have still are having, or that's maybe not as well managed, they go into the emergency room and now they get a nerve block. So that's where some of the stuff, it gives that, it's also giving patient satisfaction, not just for patients. Because one of the things with the opiate epidemic right now, we have a lot of individuals that don't want opiates. They're refusing opiates because they don't want to get addicted. They're so afraid that they take it once, they're going to get addicted, and then they're going to be addicted for life. And there's such a fear around that when we say, hey, we can give you something that's non-opiate related, and you don't have to worry about any of an addiction. That takes so much relief off of them because they're like, oh, I can do this? Yeah, we can give you something that's not going to even give you an opiate and still manage your pain, so you don't even have to worry. So there's a lot of stress reduction just on that alone. And then once they go to the ER, they're managing their stuff a little bit differently, either through nerve blocks, like I said, or the continuing medication. So they're happy because they're not getting opiates. And there's individuals that still need opiates, but there are individuals that are like, hey, I feel better because I'm not seeing all of these other side effects because of that, the constipation and all the other risks that go along with opiates and the long-term potential dependency. So they're a lot happier overall because even when they get out, they're like, oh, I can just take Tylenol. You don't have to give me an expensive medication. I don't have to go to the pharmacy and pay my $30 and $100 or whatever. If I maybe have poor insurance, I can go down and pay $20 for a big bottle of Tylenol and Motrin. Okay, great. And so, like, we're teaching them also too that they can manage their pain differently. That, oh, I have pain, I got to go get an opiate. They're learning that they got to take their pain management within their own hands. And Tylenol, Motrin, those kind of things are good ways for them to be able to do that.
Now, I imagine that a few of our listeners out there are thinking, oh, are you trying to advocate for removing the traditional BLS methods of managing pain, the simple things, the ice packs, the elevation, the immobilization, the splinting? But you're not saying abandon those tried and true BLS maneuvers. This is just something after you have done those things, as you're trying to find ways to manage that patient, that if they got their pain by splinting and icing down from a 10 to a 9, this is now to get them from a 9 lower. We're not giving up on our traditional methodologies.
No, we're still staying with their same BLS modality. So again, splinting, those kind of things, ice packs, elevation, like all those things that we learned for splinting, those stay in place. Those are not being removed. What we're trying to do is, like you said, advocate for, okay, yes, that only goes so far. Sometimes that works great and that's all they need. That's perfect. They don't need medications. But there are a lot of times that doesn't. So that's used in conjunction with that. So splinting, okay, that doesn't reduce the pain. How about some medications behind that? And like I said, some of these can be given by an EMT basic if your state allows it. So again, these agencies in these rural areas that's maybe all they have, this is another great way for them to be able to do that. And then when they have an ALS rendezvous, okay, maybe then we can start looking at either continuing that or not managing their pain, and then we can go to the narcotics or controlled substances. So like it gives a lot of modality and a lot of breadth and adding more adjustability within that. Again, it's giving the providers tools and then use the tools what's right for the patient, because that's really what it comes down to. Instead of saying all we have is opiates, now I have these different paths that I can take, and let me treat my patient like a clinician. That's really the goal. Be a clinician. Treat that patient as you feel is the best way to treat that patient.
Man, isn't that just something we all have to do? Treat our patients, do what's best for them. So really, as we close out, I have one question looming. when am I going to hear you lecturing on this topic at a conference? What conference are you going to be going to, and where can I go to listen to this? I definitely want to hear more about this.
Well, it just depends on where you can catch me. So I just spoke about this topic at the Wyoming State Trauma Conference this year. We have a trauma conference here in Laramie County, and I actually spoke, but I made sure that one specifically for the EMT basics and talking about nitrous oxide and over-the-counter medications as far as pain management, and in conjunction with what we were talking about with splinting and ice and elevation and those kind of things. A lot of it is, it's just got to get picked up on the national circuit is it. I put in for EMS World, so all I got to do is get some love and selection, and we'll be right off.
Well, there we are. Hey, those of you guys who are on that committee making the decisions about who gets to lecture next year at EMS World, you definitely need to look up Brice Jacobson, City of Cheyenne, Fire Department, Laramie County, Emergency EMS System. Definitely need to get him on the books for doing that. So as we close out, one last question for you. What is the last word? What is the best word when it comes to pain management, Brice? What would you like to leave our viewers knowing about when it comes to this super important topic?
The one thing I want you to know is we always start with BLS before ALS. Sometimes the simplest works, sometimes it doesn't. But again, the biggest thing is use your head. You be a clinician. We teach you a thought process. So go ahead and use it. Not every patient fits within the protocol. Not every patient fits within the little box that we see in our textbooks. So, again, as long as you keep going forward and do what's right for the patient, that's our biggest goal.
Always do what's right for the patient. Well, that's it for this episode of the Red River Medic podcast, where we break the rules, we challenge the norms, and we try to save lives. Not always in that order. I want to thank our guest today, Mr. Brice Jacobson with the City of Cheyenne Fire Department. He is the EMS coordinator in the Laramie County EMS system. Hopefully we'll be catching him soon at a conference near you. So remember, leadership isn't about titles. It's about action, attitude, and having the guts to do things differently. If you like what we heard, share this podcast and let's be the change we all need and want in EMS. And remember, always follow your EMS protocols and your EMS medical direction. We are not your EMS advisor, so please confer with your own medical direction and your protocol sets. So hey, from the Red River Medic podcast, stay curious, stay bold, and never stop learning. We'll catch you next time. Same river, same chaos, just some new ideas. Have a great day, everybody.